Up until 15 years ago, the only anticoagulant we really had was warfarin. And that was quite a hazardous drug to use in cancer patients. And we would find that with thrombosis, there was a high rate of recurrent thrombosis, up to about 16%, and there was a high rate of bleeding. Then at the turn of the millennium, there was a landmark study called the clot study, which demonstrated that low molecular weight heparin reduced the rate of recurrent VTE by 50% without any worsening of bleeding complications. Several studies with low molecular weight heparins came after that, demonstrating superiority. So current recommendations are that patients with cancer-associated thrombosis should be treated for a minimum of 3 to 6 months with weight-adjusted dalteparin. Then what we do at 6 months is made on an individual basis, but people with ongoing active cancer should be considered for long-term anticoagulants. Now, there are benefits to low molecular weight heparins. The fact that it's weight adjusted, so you don't need to check levels. They have very few drug-drug interactions. And whilst patients wouldn't choose to have an injection if they could, the fact that it is the most efficacious drug, the safest drug at the time, they would opt for that. They want something that doesn't interfere with their cancer journey, their cancer treatment. Now, more recently, the direct-acting oral anticoagulants have demonstrated non-inferiority in treating venous thromboembolism, in treating AF. But only recently have they been evaluated head-to-head with low molecular weight heparin. And there have been 2 landmark studies, Hokusai Cancer, VTE, and Select-D. That was comparing edoxaban with low molecular weight heparin and rivaroxaban. Now, they have shown that there is definitely a role for DAOACs in the treatment of cancer-associated thrombosis, but I think there are certain caveats to that. One thing we know is that both studies showed a high major bleeding rate in patients with GI cancers, so I think we have to avoid them in that population. There was also a suggestion, although it wasn't statistically significant, that there may be some additional bleeding in urothelial tumours. So that's one issue you have to be careful with. The other is drug-drug interactions. As we are seeing more and more treatments with targeted therapies, we certainly have to be cautious with any drugs which interact with P-glycoprotein and CYP3A4, especially strong inhibitors of both or strong inducers of both. Finally, renal biochemistry, renal function, hepatic function are also very important. So my current practice, that if a patient is not receiving any cancer-modifying treatments, they are at low bleeding risk, renal biochemistry, hepatic biochemistry is satisfactory, DAOACs could be considered, and actually the new guidelines are now showing a place for them. We've only recently had the European Society of Cardiology guidelines, and the ASCO guidelines and the ISTH guidelines have all been updated, which shows a place for DAOACs. But I think we've got to be careful to select the correct patients and make sure it's safe. What does the future hold? I think we're looking at individualized care. We're in a place now where we make our anti-cancer treatments based on molecular abnormalities and genetic mutations based on the histology. I don't think it's too much to be expecting to make an individualized patient-by-patient approach to anticoagulation.